So, we are actually witnessing landmark changes in the management of advanced lung cancer, and we have moved on from reflex genetic testing, which we were doing 1 decade earlier. First testing EGFR, then if it is negative, looking for help, then moving to ROS or MET. So now we have moved on from a reflex genetic testing to comprehensive genetic profiling by NGS, as correctly mentioned by sir. So my talk will be uncommon mutations in non-small cell lung cancer. Is it correct to rely on TKI? Now, what are the options we have except TKI? We have palliative chemotherapy. We have immune checkpoint inhibitors. We all know that the platinum-based doublet chemotherapy gives the historical the PFS was not that great. It was 4 to 5 months only, and the median OS was hardly 10 to 12 months only. So let's see how TKIs are doing in these uncommon mutations. Now, first of all, we need to understand that though these uncommon mutations they are not so common, they are 1 to 2%, but together they form a substantial number of patients of non-small cell lung cancer. And most of these uncommon mutations, they are actually poor prognostic factor. They are not a very good responder to chemotherapy as well as immunotherapy. So let's find what is the data. Now we know that exon 19 deletion and exon 21 L858R are the common EGFR mutations, and in uncommon EGFR mutations, probably afatinib do better than any first line TKI. And irrespective of mutations, we all know that osimertinib should be the first choice. Now there are some uncommon EGFR mutations like exon 20 insertion, which is a center of interest these days. So exon 20 mutation, they are not good candidate for conventional TKI, and when they were tried to exposed with chemotherapy and bevacizumab, the outcome was not that great.
Your slide is not moving.
Okay. Now?
Yes, sir.
Okay. So,
yes, sir, please put up in full screen mode, sir.
Pardon?
Full screen mode, sir. Your slides were not moving. Full screen.
Now it's moving. Moving?
No, sir.
So whenever I am making it full screen, they are not moving. If I zoom out from full screen, then they are moving.
Yes, it is moving now. Yes, okay. Yes, it is okay. It's okay.
So I was trying to say that there are some uncommon mutation which are exon 18, G719X, or exon 21L861Q, where if afatinib does better compared to other first line TKI. And another unique mutation is exon 20 insertion, which is also constitutes of 5 to 10%. They don't do better with TKI, and the chemotherapy plus bevacizumab was tried, but there was a modest improvement of PFS. See the PFS with chemotherapy plus bevacizumab, median PFS was only 7.5 months. It is not, we are not happy to get that. So immune checkpoint inhibitors were tried, and even with immune checkpoint inhibitors, the median time to next treatment was also very dismal. It was only 3.7 months in EGFR exon 20 insertions. So that's how the role of newer TKIs came in place. First, one strategy was to double the dose of osimertinib, that is 160 mg daily. See the diagrams, it shows that most of the patients, they had partial response at least or stable disease. In Zenith 20 trial tested the role of osilotinib in such situation, and here in median PFS was only 5.5 months, but finally there was some improvement with mobocertinib with a overall survival of 24 months and median time to duration of response with 17 months, more than 1 year. And we all know the impressive data of phase 1 Chrysalis trial with amivantamab, which showed that the median PFS was 8.3 months in such a bad prognostic disease, and a median OS close to 1 year, 22.8 months. Now coming to other uncommon mutations, probably we are all convinced that for treating ALK rearranged tumors, different TKIs are available, and we have moved from the first generation TKI crizotinib to second generation like alectinib or ceritinib, or even brigatinib and lorlatinib are also approved to be used in first line setting. And that's impressive almost doubling of the PFS when we use this newer generation of TKI. However, though the OS was not significant all the time, and it is because of the crossover allowed in the trials. So and these newer generation TKIs, ALK inhibitors, they have very excellent CNS penetration and CNS control rate. Now coming to another uncommon mutation, which is ROS1 rearranged. Now profile 1001 was tested for crizotinib in ALK rearranged, but this trial has an expansion, and in that expansion 53 ROS1 positive patients were enrolled, and they were treated with crizotinib. Look at the objective response rate. It is very impressive, 70%. With a median duration of response of 17 months and median PFS of 19 months. So even the NCCN also approves the use of crizotinib and entrectinib in the first line setting in ROS1 rearranged non-small cell lung cancer. Coming to another uncommon mutation, which is MET exon 14 skip mutation. We all know that capmatinib and tepotinib, these two TKIs are actually available, though different type 1 or type 2 TKIs are available, but these are the two drugs which are available. And see the median PFS with capmatinib in treatment naive MET exon 14 skip mutations. The median PFS was 12 months. Please remember, these are the patients who are actually the prognostically very unfavorable group of patients. They are not like EGFR mutated patients. And tepotinib had a median PFS in first line setting 8.5 months, and see that they have some response in even in second line setting also. So these are the different investigational TKIs which are in investigation in different phases in MET altered non-small cell lung cancer. Now coming to another uncommon mutation, which is BRAF mutation positive. We all know that single agent vemurafenib or dabrafenib was not good enough because of the downstream signaling pathway resistance mechanism. So in BRF 113928 trial in cohort B, when both the dabrafenib and actually trametinib, both these combinations were used, the median PFS was 8.6 months, which is not bad as far as the historical cohort of chemotherapy. The PFS we achieve with chemotherapy, which is close to 4 to 6 months only. So this is the updated OS with dabrafenib plus trametinib in second line, and the median OS was 18 months, not bad. And Now another uncommon mutations that is red receptor tyrosine kinase, and for red fusions in non-small cell lung cancer, we all know that selpercatinib and pralsetinib, these are the two approved drugs. Now selpercatinib had a median PFS of 22 months in treatment naive. See the response, the overall response rate was as high as 84%, which is close to the response rate we see with geftinib and allotinib in EGFR mutated patients. The pralsetinib also had an overall response rate of 70%, with the median PFS of 9.1 months in treatment naive patients. So they both the drugs got FDA approval. Now coming to NTRK gene fusions. So NTRK gene fusions in NTRK inhibitors, entrectinib and larotrectinib, these are the two drugs, and with the median PFS as 13 months or 28, even 28 months. So with the overall response rate as high as 64 to 73%. So we are quite happy with these TKIs. And now coming to HER2 mutations, we see two kind of HER2 dysregulation in lung cancer, either HER2 mutations or HER2 amplifications. The strategies are either you use a antibody drug conjugate like trastuzumab emtansine or trastuzumab deruxtecan, or you use a bispecific antibodies. Now, this is the data of TDM1, which showed that most of the patients in this series, they had either partial response or stable disease. And this is the actually Destiny Lung 01 study design, where there were two cohorts, HER2 overexpressed or HER2 mutated. And in both the actually cohort, trastuzumab deruxtecan had good efficacy, showing most of the tumors showing tumor shrinkage. And these are the PFS and OS curve. The median PFS with deruxtecan was 8.2 months with a median OS of 17.8 months. So I repeat, these are the patients who are prognostically poor group of patients, and still if we can achieve a median OS of 17.8 months, that is quite impressive. But please remember, both the setting, the drugs were the HER2 directed drugs were actually used in second line setting. So this was a summary and key takeaways from Destiny Lung 01 trial. And so this is the actually the diagram showing that the use of HER2 directed therapy in second line setting. Now so by this time we all are I think we all are convinced that these multiple TKIs, they do better than conventional chemotherapy. And though it's a very complex scenario, it's not like that the patient only can harbor only single mutation. Only deep sequencing NGS can tell you that there can be complex mutation status, and which can also guide your therapeutic choice. What about applying immunotherapy in such uncommon mutations? So this was a data of very robust data of 500 more than 550 patients who had driver mutation, who had driver mutation positive lung cancer. And the result from the immunotarget registry showed that the role of immunotherapy in this driver mutation positive lung cancer showed most of the time in driver mutation positive lung cancer, immunotherapy had the efficacy is questionable. Most of the partial response rate was as low as 10 to 15% only, except there were two exceptions which were KRAS mutation and one was BRAF mutation. These are the two driver mutations which had some modest activity of immunotherapy. In other driver mutation cases, the role of immunotherapy was clinically not meaningful. So, to summarize, this is a very beautiful slide in which actually they tabulated the approved drugs for uncommon mutations. This will be my last slide in EGFR exon 20 insertion. Amivantamab or mobocertinib, ROS1, crizotinib or entrectinib. For rate rearrangement, we have selpercatinib or pralsetinib, NTRK fusion, larotrectinib or entrectinib, BRAF V600E only, not in other BRAF mutations, dabrafenib and trametinib, made exon 14 skip mutations, capmatinib and tepotinib. And very interestingly, now we are having sotorasib also in KRAS G12C mutation. So to summarize, we have made great strides for patients with uncommon mutations. Multiple potential targetable mutations makes it more difficult to keep it all straight, because we all know that complex mutations, they do exist. So we'll continue to see new and better treatment emerging for these and other targetable mutations in future. So with this, I thank you all for listening me patiently. Thank you.
Dr. Sudeep, thank you for such a wonderful presentation. You almost covered all the aspects of uncommon mutations. So if there are any questions, we can take few questions. So one of my questions, Dr. Sudeep, so you have started doing NGS for all your patients, or you are doing sequentially for first EGFR, ALK, ROS, MET, and then followed by NGS? Because these all uncommon mutations we tend to find only when we deeply dive into the genomes of the tumor. So are you doing NGS for all of your patients?
Sir, we have stopped doing reflex testing. First of all, our pathologists give information about ALK and PDL1 from IHC. And in most of the patients we use the coupon which is available for at least 12 gene lung panel, limited lung panel. There are some patients, 10% patients who have access, they go for broad lung panel. But in most of the time, we are doing at least limited lung panel. But it is for sure that we have stopped reflex testing one after another.
Okay, so what we are doing in our institute, so once we order NGS, we find that at least 3 weeks times are needed. So for all our patients, we will do EGFR, ALK, ROS, MET, and reflexly the samples would be sent for NGS also. So in our institute, we get these reports within 5 to 7 days time. And then if the reports are negative, we start the patient on chemotherapy and wait for NGS. Or otherwise, if the reports are positive, we start with the available results, because the turnaround time is, I think, very, very important. So your experience with a few uncommon mutation, can you share any? So complex mutation, uncommon EGFR mutation, can you shed some light on that?
Yeah, I have two patients. One is actually on capmatinib, which was exon 14 skip mutation positive. Is doing well in capmatinib, and unfortunately, the capmatinib patient assistance program got over. He was not progressing on capmatinib, but I had to put him on chemotherapy once the free drug coverage that program was over. Another patient who is receiving tepotinib actually primarily was a EGFR mutation positive patient, and then as a resistance he developed exon 14 skip mutation. So we are treating him with a osimertinib plus tepotinib combination.
So that is, I think it is very true. So once we are doing NGS for all our patients, we can directly look into the heterogeneity of the tumor. And I share one of my experience with this NGS. And upfront, we had a patient who had EGFR exon 19 mutation in exon 19 plus MET also. So this being a poor prognostic sign, we we asked for capmatinib as a compassionate usage. We started this patient on osimertinib plus capmatinib upfront, although we know that we don't have the approval for the same, but I can tell you that this patient is still doing fine with us, and this is post 7 months down the line. So I think NGS has a great role to play. And Dr. Sudeep, you did your job really well. Thank you so much. We will invite our next speaker.
Thank you, sir.
Thank you.